Yes, good afternoon, everyone, and good morning to our colleagues in the US. Thank you all participants for joining in again. We'd like to welcome you to our 12th session of our Pediatric Emergency Medicine lecture series. We're very happy to say that it has been a very successful year since we began our Pediatric Emergency Medicine lecture series in January. So we are very happy to have this session today, which is the end of the year, and it's going to be the last session for this year. But as we have always said, it's going to go on to the next year, and it's going to be again every month. So every month we have been having this lecture series, and today we are very happy to have a very interesting topic, and we are gladly to have a good number of presenters or keynote speakers that have joined in us today, and they're going to be with us. And this is a very special Pediatric Emergency Medicine lecture series for today. And if for those that have been following us up, when we began in January, the main aim was to increase the awareness of pediatric emergency within the country, since it's a new field. And we're very happy to say it has been very successful. And as of today, as we speak, MUHAS under the Department of Emergency Medicine has initiated a new super specialization course that is Masters of Science in Pediatric Emergency Medicine. And those that are pediatricians or emergency physicians are all eligible. And for this year, we are very happy to have three new pediatric emergency medicine fellows who have joined in into our newly program. And these are going to be the pioneers of this program. And so to speak, they are also the ones that are going to be presenting in today. So we're very happy that the journey that began in January with the hope of beginning the new specialty has now been a success. And we are very happy to introduce our three newly enrolled pediatric emergency medicine fellows. And today we are going to have Dr. Asha Yulu, Dr. Biita, and Dr. Juma Mbugi, who are the newly pediatric emergency medicine fellows at MUHAS. But also with us, we have Dr. Greenky, who is going to introduce himself as he comes, with an assistant professor from Emory School of Medicine, and Dr. Anna Goebel, who is also a pediatric emergency medicine fellow who has joined us today from Emory University. So it's going to be a very interesting talk. And I would like to welcome you once again to this talk. So without wasting much of time, just a few things also to put into perspective. This is a CPD accredited activity whereby at the end, you all have to write your MCT numbers on the chart and will claim your three CPDs once the session has been done, and I'll make a follow-up. Welcome once again and enjoy the session. I would like to welcome Dr. Greenky. Go on. Thank you.
Hey, good morning, everyone. My name's David. I'm one of the pediatric emergency medicine physicians at Emory Children's Healthcare of Atlanta. I've been fortunate enough to come to Tanzania a couple of times, three times actually, and I'm hoping to be able to come again soon. I am going to just give a very brief introduction to some basic things that you should be thinking about when uh, doing procedures in children. And I tried to keep it a bit general because all of these things that I mention will be talked about, will be touched on in various ways by the presenters going forward. I just wanted to give a very brief, larger overview. I think that the biggest thing to keep in mind when thinking about procedures in children, which is really the same when you're treating children in the emergency department, when you're doing any sort of treatment with the children in the emergency department, is that children are different. Kids are different than adults. Kids are not simply just small adults. And even more challenging, kids change with age. So, a one day old neonate is going to be pretty different from a 12-month-old infant, who's going to be different from a 4-year-old, who's going to be different from an 8-year-old, who's going to be different from a 12-year-old or a 16-year-old. And each of those age groups have their own specific needs that you have to consider. In general, some things you should keep in mind is some of the anatomical and physiological differences that children have. For example, the way that children metabolize medicine, which also changes, by the way, with their age. The size of the equipment that you need to use in children also changes with age. The anatomy of children, for example, the difference in the anatomy in the airway in children. The airways are smaller, they tend to be more anterior, etc. Uh, Behavior. So obviously, it's in general, it's going to be much harder for you to get a 2-year-old to cooperate than a 12-year-old. And these are all things that you need to be thinking about when you're doing a procedure. And the key is in planning. Uh, so, a couple things to remember. Number one, to have a successful procedure, you want to be able to keep the child still, and there's different ways to do that. And number two, obviously, you want the child to be comfortable. How do you keep a child still? Well, there's different ways. You could use diversion tactics. So if you happen to have a smartphone that you can watch a video on to distract the child. Sometimes we have to wrap up the child in a sheet, what we would call here a burrito. If you're familiar with the Mexican food burrito, it's a piece of dough that wraps a bunch of ingredients inside, and so you can sort of do that to the child with a sheet. We use different medicines to make a child more comfortable, to decrease their pain, sometimes even to sedate them. And then the last thing that I would keep in mind is talking to the parents and making a plan, and trying to include the parents in your plan from the beginning, prior to the planning stages. And even if you know what you want to do, getting the parents buy-in and having them join you as a teammate will always be helpful. So those are some basic things that just to keep in mind. And again, I think all the presenters will touch on these things one way or another. And so without further ado, I'd like to welcome Dr. Juma to present the first procedure.
In 1 minute.
Dr. Britt, can you unmute Dr. Juma, please?
Yes.
Thank you. Greetings, everyone. So I'm going to talk about the placement of nasogastric tube in children. Mbugi, one of the 3 candidates of pediatric emergency medicine at MUHAS this year. So our topic will concentrate on introduction, indications, contraindications, placement and confirmation of placement, removal, and complications. So nasogastric tubes are flexible double or single lumen tubes that are passed proximally from the nose and distally into the stomach. The single lumen tube is the most common type of the nasogastric tubes. And the double lumen tube, the larger lumen usually serves as the function of drainage and suction, and the smaller lumen acts as an air vent to prevent the tube from sticking in the gastric mucosa. So what are the indications of nasogastric tubes? Decompression of the stomach and the proximal bowel for obstruction or in trauma, gastric lavage in children with upper GI bleeding, or an ingestion or overdose of substances. Administration of medication rehydration solution or for feeding purposes. And obtaining gastric content samples for laboratory analysis, especially in the diagnosis of Mycobacterium tuberculosis in children that can not produce sputum. So they usually cough and swallow the mucus. So you can do the gastric lavage to obtain the gastric content for lab analysis. Contraindications, children with esophageal stricture because of the risk of esophageal perforation, base of skull fracture and other fascial fractures due to the potential of tube going into the intracranium. Esophageal varices, the tube may trigger life-threatening variceal bleeding. And children with bleeding tendencies, because even very trivial trauma to the pharynx, esophagus, or stomach can cause life-threatening bleeding as well. So what are the procedures to follow? First, you choose the nasogastric tube size. Usually choose the largest size feasible, but the tube should not cause discomfort to the child. Generally, a newborn will require an 8 French gauge. By age 1, 12 French gauge is enough. And a teenager will usually tolerate a size of 18 French gauge. And for ages in between, usually choose the size accordingly. But there is a rule of thumb that NG tube size is generally twice the size of the endotracheal tube. For instance, if the ETT of your child is 4, then the nasogastric tube will be 4 times 2. That is 8. And if you don't know how to calculate the ETT size, this is the formula to calculate the ETT size. This is modified Colles formula, which says 18 years over 4 plus 4. So what are the other considerations? In adolescent overdose, for instance, you can use the largest size, 28 to 40, to facilitating efficient removal of pill fragments from the stomach. Although this practice of using the lavage to remove the fragments from the stomach is rarely used nowadays. So how much length should be inserted? So estimate the length to be inserted by adding 8 to 10 centimeters to the distance from the nares to the xiphoid process. You can see the illustration over here. You measure from the nares to the xiphoid process, and then from the xiphoid downward, you measure 8 to 10 centimeters additional. And this, the whole length is the length that will be inserted in. But again, there is another method, which is a nose earlobe xiphoid process method. So this involves measuring the length from the tip of the nose to the earlobe and then to the xiphoid process. This is the whole length that should be inserted into up to the gastric. And this is also an illustration that shows how to measure the length to be inserted in. So what are the steps to take? So always some people, some centers, they advocate the informed consent from the parent or the caregiver, and then prepare the child by explaining the procedure. You can explain the procedure to the parent as well, and to the child if the child can receive your explanations. And sedation is rarely required in nasogastric tube placements. How do you position the child? Older children who are alert can remain sitting, and infants and obtunded children require the supine position with their heads turned to the side, like the picture shows. And then apply topical anesthetic spray. This although will actually decrease the gagging. And then straighten the curved tube and check its patterns with a syringe. Apply a sterile water-based lubricant or lignocaine gel to facilitate the nasal passage. Grasp the tube 5 to 6 centimeters from the distal end and advance it posteriorly along the floor of the nose. So careful when you're advancing it, because if the tube is incorrectly directed to the nose, may cause a laceration of the inferior turbinate and cause bleeding that can be difficult to control. So insert the tube with the natural curve of the tube pointing downwards to pass the bend of the posterior pharynx. A cooperative child can be asked to flex his or her head slightly forward and to swallow some water to assist in glottic closure that can ease the passage of the tube into the esophagus. But again, if the child is not cooperative, an assistant can assist in the flexing the infant's neck. So sometimes a child can start gagging persistently, or sometimes when you insert the NGT through the nose, you find it emerging from the mouth. So when this happens, temporarily discontinue the procedure and support the child until they recover from the discomfort. So how do we confirm the placement? So when the tube is successfully inserted to the measured length, usually check its position. You can make a mark, and then auscultation, attach a syringe filled with air to the proximal end, and while depressing the plunger rapidly, listen with your stethoscope for gargling sound over the stomach. So there are other additional confirmatory tests, especially in high-risk patients, that should be considered, like pH testing using a pH strip. A pH strip is just like a urine dipstick strip. So you take the gastric content and then you put into your pH strip, and then it will give you the pH of the gastric content. So usually, if the tube is inside the stomach, the pH will be less than 4. Some literature say less than 5. Another method, single frontal view X-ray of the chest, including the upper abdomen, to confirm the tube tip position within the stomach. So you can see the next slide. You will see the next slide. The tube tip should be inside the stomach. So after this, you tap the tube securely to the nose using the tincture of benzoin. The tincture of benzoin actually helps in sticking. It helps to stick the tube to the skin. It fastens especially in children with diaphoresis. So this is an X-ray that shows the correct placement of the NGT. You can see the tip here is inside the gastric bubble. This is the correct placement of the tube. So the other methods that can be employed is the use of ultrasound to confirm the NGT placement. So for those who are familiar with ultrasound, usually you use a curvilinear probe on the abdomen to see the tube in the stomach. You can see the hyperechoic structure over here. I don't know if it is seen from this hyperechoic structure imaging into the gastric contents. This is the NGT. So the evolution of point of care ultrasound is an alternative to traditional methods like radiography that can be very useful in children and in critical care settings. There are some studies concerning ultrasound in NGT placements. This is one of the studies that showed that the results suggest that bedside abdominal ultrasound has a good predictive value and may confirm the correct placement of NGTs. However, considering its suboptimal specificity, which was 91, caution is necessary before implementing this technique into clinical practice. So what should you do when the NG tubes clog? So if the tube clogs, here are some of the recommendations to declog the tube. Start with gentle back and forth flush of warm water using 30 or 60 ml syringe. Allow to sit for 5 minutes and repeat flush actions. So do not try to force the water into when you are doing this procedure. So you can push the water gently and then leave it for 5 to 20 minutes to allow it to dissolve or to soak the clog. After a while, you can repeat the procedure until the clog disappears. The other method to declog the tube is enzymatic declogging agent like clogzepam. And there is a practice of using coke, which has carbonation in the acidity. It has an efficient declogging ability, but the use of Coca-Cola, for instance, is debatable in declogging the tubes. When do we decide to remove the NG tube? Nasogastric tubes should be removed when the indication for placement no longer exists. We can remember the indications for NG tube. So whenever those indications are no longer there, then there is no need for NG tube, then you have to remove it. And the removal is usually uneventful, but when you remove it, whenever you find a resistance upon attempting to remove, you should stop removing it and actually obtain an X-ray to see what's happening, because NGT can make knots, and when you forcefully remove it, you can injure some structures. What are the complications? One of the biggest complications is tracheal intubation, trauma or laceration of the nasopharyngeal or esophagus as well. Reflux or vomiting leading to aspiration, direct airway instillation of tube contents, especially if you have done a tracheal intubation. That means all of the things that you are instilling will go into the airway. Whenever it's medication or food. So you can see these 3 images. The middle one is the correct placement of the NGT. You can see the tip here is within the stomach. And then the left one, you can see the tube kinked and coiled itself. So this will not serve a purpose because it has kinked and it has coiled. The right one, the right image, you can see the endotracheal intubation of the NGT, and unfortunately, this means they did not confirm its placement, and they started feeding or giving medications, and everything went into the lungs. So, having said this, it's necessary that all nasogastric tubes placed for feeding or medication purposes be confirmed its placement by X-ray. all nasogastric tubes placed for feeding or medications purposes should be confirmed by X-ray to prevent things like this. So yeah, there are some studies again that measuring whether or not enteral or parenteral feeding is better. So everything has its indication, but whenever you decide or the two options can fit enteral or parenteral feeding, some studies shows that enteral feeding has beneficial is beneficial compared to parenteral feeding. This study is a meta-analysis that came with conclusion that tube feeding and standard care are associated with lower risk of infection than is parenteral nutrition. These are some of my references. Thank you so much.
Okay, thank you very much, Dr. Mbugi, for a very nice presentation. So for the participants, if you have any question, you can just put it on the chat and we'll gladly let our presenters know at the end. So now move to Dr. Biita, who will be the next to present. Dr. Biita, you're welcome.
Hope can you hear me?
Yes, we can clearly hear you and see your slides, and we can see you as well.
Okay, so thank you very much. Good afternoon. My name is Dr. Biita Manus. I'm going to present about lumbar puncture, and my supervisor is Dr. David Greenky, and I'm one of the candidates in pediatric emergency medicine. So in this topic of lumbar puncture, I will cover about the definition. I will talk about the indication and the contraindication of lumbar puncture. I will discuss about the preparation for lumbar puncture, and then the procedure, the steps of doing lumbar puncture, and lastly we'll discuss about the outcome of doing lumbar puncture. Then, according to American Academy of Pediatrics, lumbar puncture is defined as a procedure involving insertion of a needle into the lower back to collect a sample of cerebrospinal fluid that surrounds and cushions the brain and the spinal cord. So basically, it is tapping or inserting a needle into a subarachnoid space to collect the CSF. So what are the indications of doing lumbar puncture in the pediatric emergency department or in emergency medicine in general? So as I said, the lumbar puncture is a medical procedure which serves two purposes. One is for diagnostic purpose. Number two, it can be used as a therapeutic tool. Starting with the indication as a diagnostic purpose. One, lumbar puncture can be used to diagnose the CNS infections. And in emergency medicine, the life-threatening infections, which necessitates the lumbar puncture in emergency department, number one is meningitis, followed by encephalitis. Number two, lumbar puncture can be done in emergency settings or in emergency medicine department to diagnose non-infectious disease, non-infectious CNS disease. In emergency medicine, the life-threatening conditions, which is non-infectious, which needs lumbar puncture, number one is a subarachnoid hemorrhage. But there is other non-infectious disease which are non-life-threatening, like autoimmune disease, Guillain-Barré syndrome, etc. But in the most common non-infectious, life-threatening in ED, it is subarachnoid hemorrhage. But at this point, I want you to note that lumbar puncture is not the first diagnostic test when you want to diagnose subarachnoid. Subarachnoid, the first test is CT of the brain. If the CT does not confirm or does not reveal subarachnoid hemorrhage, and from your history and the physical examination, you still think that patient has subarachnoid hemorrhage, then the next step is to do lumbar puncture. The indication number 3 is to measure the CSF pressure. There are some pathology you as a clinician, you may need to know the pressure of the CSF. So you need to have a gadget. After inserting the needle, you connect the manometer on the spinal needle, then you measure the pressure of the CSF. Also, lumbar puncture can be used as one of the routes to administer medications. In emergency settings or in acute care settings, one example is anesthetic drugs, like those who are undergoing spinal anesthesia. But other medication, even if they're not emergency, can be delivered through lumbar puncture, like chemotherapy and contrast for imaging. Lastly, as I said, lumbar puncture is for both therapeutic and diagnostic. So, lumbar puncture can be used as a therapeutic tool in a patient with idiopathic intracranial hypertension. That means the patient has a high intracranial pressure because of excess CSF. So doing the lumbar puncture, you decrease the pressure in subarachnoid space or in the central nervous system. In that way, lumbar puncture will be used as a therapeutic tool. So this is the study which was done in France, looking on the lumbar puncture, which was done in emergency department in France. And it was found that the main assumed indication of lumbar puncture, number 1, was CNS infection. 62% of this lumbar puncture, which was done in emergency department in France, 62% was because of CNS infection. It was followed by subarachnoid hemorrhage, which accounted for 12%. I believe the situation is the same in our settings. There is another study which was done. It actually was a systematic review, which reviewed the studies about lumbar puncture in pediatric emergency. It was found that the main reason of performing lumbar puncture were to rule out sepsis or potentially severe infection in 45% of children younger than 3 years of age. And meningitis was the second indication of doing lumbar puncture in children older than 3 years of age. And among all of these children who underwent lumbar puncture, meningitis was confirmed in 44.4%. So this means infection is the leading indication of lumbar puncture in acute care settings, which also applies in our settings. So the preparation of doing the lumbar puncture. Remember, lumbar puncture is a sterile procedure. So anything, what we do for sterile procedure, in any sterile procedure, will also be applicable in the lumbar puncture. So in preparation, number 1, you need the staff. Minimum, you need 2 staff. 1 is a procedurist or the person who will do the lumbar puncture, and the number 2 will be the assistant. The another equipment we need to prepare is the equipment. Remember, as I said, it's a sterile procedure. All of the necessary steps or equipment for the sterile procedure will be needed, including having a sterile gloves, having a mask, having a disinfectant. Okay. So, but for the lumbar puncture, these are the equipment. 1 is the lumbar puncture kit or the lumbar puncture tray. So the lumbar puncture kit are some are special, which are pre-made from the factory or from the supplier. This kit will have all of the necessary minimum equipment you need. Like you will have the sterile swabs, you will have the draper, you have the bottles you need. But in other settings like ours, we don't have the special tray or kit from the factory. Rather than we make our own tray. We pack our tray for lumbar puncture. We put a guard pot, we put a sterile gauze. So we need a kit, either locally made or from the factory. So number 2, what you need in terms of equipment, you need a spinal needle. So the literature is recommending either to use 22 to 25 gauge for the children. The smaller the size, the less are the complications. So, but these needle, spinal needle 22 to 25, they also come up with different length. You may have gauge 22, but with different needle of different length, like 2 centimeter needle length, 10 or 16 or 10. So, but the gauge is 22, 25, but the length of the needle will depend on the age. So you need to have a reference of this length. And actually, the length of the needle, it reflects the distance from the skin to the spinal cord. And the literature says, usually, the distance from the skin to the spinal cord is 2/3 of the needle to be used. So after knowing the distance, you can estimate which needle do you need. You don't want to take too small, too short needle because you do not reach the subarachnoid space. And you don't need too long needle because you go too deep, you cause some complications. So other equipment you need is antiseptic, you need a local anesthesia, you have a CSF container. You need a container because after doing lumbar puncture, you need to collect a CSF. So number of containers or which container, may differ from hospital to hospital. So make sure you watch or you see the recommendation from our hospital. Do you need a 3 bottle? Do you need 2? Do you need 3? Do you need 4? But the literature is recommending the standard is 3. 1 bottle for biochemistry, 1 for cytology, and 1 other for microbiology. But make sure you do the reference to your hospital because some, they say you take the red bottle, bottle with the red cap, other take with the green or whatever. So make sure you make a reference on how to correct the sum. Another equipment you need is a manometer with a 3-way connector. This manometer is for measuring the opening pressure of the CSF. As we said, one of the indication of lumbar puncture is to measure the CSF pressure. So you need to have a manometer. In our setting, if you don't have, fine. But if you want to measure the pressure, you need a manometer with a 3-way connector. Other equipment you need to have a cardiorespiratory monitor. Remember, carving a child or holding the child in a position of a lumbar puncture may be accompanied with respiratory compromise. You may compromise the airway. So having a cardiac monitor in place will let you know how the child is progressing during the lumbar puncture. So another preparation of lumbar puncture is to review the indications before you perform the lumbar puncture. Remember, creating a communication between the central nervous system and the external environment is a sensitive thing. So don't make a decision of making a lumbar puncture means creating a communication between the external environment and the CNS if you don't have a clear indication of doing the lumbar puncture. So ask yourself, is really lumbar puncture needed in this child? If it's not, then we need not to do it. Number 2, you need to discuss with your senior and the shift before progressing or continuing with the lumbar puncture. So the senior and the shift will help you to review the indication, the contraindications. Another part of the preparation is you need to ask yourself, how long will it take for you to make or to complete the lumbar puncture? Remember, we want to diagnose infection, and the infections is time sensitive. So the literature says, if you cannot accomplish lumbar puncture within 30 minutes, it is better go ahead and give antibiotics without waiting for the lumbar puncture. There are other means can be used to confirm meningitis rather than waiting to complete lumbar puncture and then to give antibiotics. 30 minutes, you cannot accomplish lumbar puncture, go ahead and treat infections. So what are the contraindications of lumbar puncture? One is low GCS, or the child is the GCS is progressively deteriorating. This is a bad sign. So if you have such a child, it's better not to do the lumbar puncture. Other contraindication is signs of raised ICP with signs of brain herniation. What are the signs of brain herniation? Remember the Cushing triad: irregular respiration, bradycardia, high systolic blood pressure, papilloedema, decerebrate posture, decorticate posture, abnormal pupillary response. So if you see these signs, it means the child is herniating or has impending brain herniation. So doing lumbar puncture in that child, you reaccelerate the process of herniating. So if you see these symptoms, it is contraindicated. You should not do it. If we are in doubt that if this child has a raised ICP or not, it is better to do a CT before doing the lumbar puncture. Another contraindication of lumbar puncture is spinal bifida. Remember, you have the spinal bifida and you want to insert the needle there. So it is absolutely contraindicated. If you have infection on the site where you want to put a needle, to insert a needle, it is a contraindication because you are going to introduce the infection into the CNS. Then, as a part of the preparation, you need to plan which position are you going to use to do the lumbar puncture. There are only two positions can be used to do lumbar puncture in children. One is the sitting position. You can see the child has to sit, has to flex the hip and the knee towards the chest. This curving, it helps to increase the space between the vertebra where you're going to insert the needle. If you don't curve, the space between these vertebrae becomes small and there's a chance of missing is high. The second position is lateral decubitus position, which is this one. Again, remember, you need to curve the child. As I said, this process of curving the child may compromise the airway. So having a cardiac monitor will help you to monitor the patient. After making this position again, you need to draw an imaginary line, which will help you to show where are you going to put or to insert the needle. So this line is drawn from the posterior iliac crest. Both sides you join those two crests. This line intersects at L4. At L4. So from L4, you can know if you want to insert the needle in L3, L5. So you can estimate from there. If you want to insert the needle in L4, L5, this line will guide you, will show you where to insert the needle. Again, now you have done all of this, you have prepared the patient, your position, everything is gathered. Now the process of doing the lumbar puncture. So number one, as I said, is to position the needle in the midline. This is the child. Then you put you have drawn an imaginary line, and now you know the L4 or L3, L4. So in children, the needle is inserted between L3 and L4. Later on, we'll discuss why this space. So after drawing the line, you need to put the needle at the center. And then after that, you need to advance. You need to advance the needle directing to the umbilicus. So it means we need to be at an angle, as you can see on the left side, on my right, this one. So the needle will go at a certain angle, and it's not perpendicular. You target to go to the umbilicus. So after that, you advance the needle. You advance the needle going through different structures. You go through the you'll go through the sorry. So you go through the different structures from the skin, subcutaneous tissue. You go through the supraspinous ligament. you go in until you reach the subarachnoid space. So, but the literature says the bevel needs to be parallel to the spinal cord. This will help to avoid cutting the fibers. So if the patient is in sitting position, so the bevel will need to point upwards. If the patient is on if the patient is sitting position, the bevel will point on the to the side, and if the patient is on the lateral decubitus, then the bevel will point upwards. This is to avoid puncturing the fibers. So after that, if you feel the resistance has decreased, then you know you are in subarachnoid space. But remember, these children, the skin, these ligaments, they are so soft. It's not like an adult. They're not calcified. So you may not be able to feel the decrease in resistance. So you need to remove the stirret and check if there is a CSF coming or not. If you see the CSF is coming, then you remove out the stirret. So why do we need a stirret? The stirret has several functions. One, it creates a rigidity to enable you to advance because the needle is so soft. If you go without a stirret, the needle is so soft, you not achieve that. Number two, the stirret, it helps to prevent from moving different tissue from the skin to the subarachnoid space. And again, the stirret, it makes sure that the needle, spinal needle, the lumen remains patent despite of advancing through different structures. Then, after noting that when in subarachnoid space, the next step is to correct the CSF. So how much do you correct of the CSF? Remember, as I said, your hospital, how much of the bottle are you taking? If you did 3 bottles, then make sure you correct 3. If it's 4, you correct 4. But the literature, the standard is 3. So the literature says 1 ml, it may be enough for each bottle, but it may depend on your institution. Then after that, you replace a stirret, and then you remove a needle. After that, you do occlusive dressing to prevent the continuous leakage. So you occlude, you dress. Then after that, you send the specimen to the lab. After completing this procedure, you need to make a critical documentation. What are you documenting? Document how the procedure was done, what difficulty did you face, any difficulty you faced, any trauma, any complications, what sample do you take, how many, what sample do you take, how many bottles you take, what test do you order after that. So you need to make a critical documentation. If a consent was obtained from the family, make sure you document that. Then I have explained this procedure. You may think it is simple like that they were explained, but it is not true. So the different studies have pointed out that in emergency department, there are a lot of negative lumbar puncture. Meaning what? We are inserting the needle, but we don't get a CSF. This is called a negative lumbar puncture. And not only that, but also we do traumatic lumbar puncture. Instead of draining the CSF, we end up draining blood. That is called traumatic lumbar puncture. So there are different studies around the world looking how the emergency medicine can maximize or can make lumbar puncture successful as much as possible. So one of the suggested solution was the use of ultrasound. So bedside ultrasound can be used to improve the success of lumbar puncture. What does ultrasound do? The ultrasound will help you to measure the distance from the skin to the subarachnoid space. So you know how deep you need to go. And from that, you know which length of the needle you need. But not only that, the ultrasound will help you to allocate where is L3, L4, where is L5, L4, L5. So this study It reviewed 7 randomized controlled trial, which involved 618 participants included in the lumbar puncture. So actually, the patient came into two groups. One group, the ED physician used the
Okay, so I think Dr. Biita has just lost his connection as he was about to finish up, but I'm sure he'll join us again. Hello, Dr. Biita, can you hear us? We cannot hear you.
Sorry, okay. So the last
Yes,
slide is about analysis of the CSF. So you need to know the normal, and the normal composition differ from age to age. So you need to have a normal CSF glucose, a normal CSF protein, depending on the age, so that you can know the interpretation. Even on the analysis, in terms of microbiology, in terms of the cytology, you need to know the norm. For example, a normal CSF is clear and colorless. The white blood cell in a normal CSF is less than 5, and usually it is lymphocyte. But when we have bacterial infection, the CSF will increase and there will be more of a neutrophil. And the protein, the normal is about 15 to 40, but when we have the bacterial infection, it may go high. So you need to have a normal reference for interpretation. You don't need to claim this. What you need a chart for interpretation. So this, so the last slide is about what is the difference between a lumbar puncture in adult and lumbar puncture in pediatric. Number one difference is that in the preparation, the children are not cooperative. We need to have different methods to calm them down, which is different from the adult. The needle we use for the children, we need to use a shorter needle and the gauge. Another difference in an adult with the adult is the interpretation of the result. The opening pressure is different. the composition is different. Thank you very much. That's the end of my presentation.
Thank you very much, Dr. Biita, for a very detailed and well-explained lumbar puncture procedure. And I know there are questions that are on the chat, which, as we said, will definitely be answered at the end. So just to inform all the participants that have joined, I know we always have our Zoom in 1 hour set, but given today we have some more common procedures to present, I would like you to bear with us for a few more minutes so that our next presenter can also present the next two procedures, which are very important and very crucial. So we're not going to stop the Zoom. We're going to go on until the two presenters are done. So just stay with us and be with us to keep on learning. So I'd like to welcome Dr. Hannah for the next procedure. Yes, Dr. Hannah, you are now welcome to share your slide and begin presenting.
Just pulling it up. Okay. Good morning, everybody. Thank you for having me this morning. My name is Hannah. I'm one of the third-year residents working with Dr. Greenky and Dr. Murray at the Emory Children's Hospital in Atlanta. And I'll be one of the incoming pediatric emergency medicine fellows for next year's class. So I'm very excited. So I've been spending a lot of time in the emergency room, and this is one of the procedures that I've had a lot of experience doing. So I'll be talking about incision and drainage today in pediatric patients. So today we're going to talk about incision and drainage as primary treatment for a skin or soft tissue abscess. We'll talk about how it can be used with or without adjunctive antibiotic therapy. And these are very common findings. A lot of presentations to the emergency department will see for these pretty much anywhere on the body. But in children, we'll most commonly see them in the pelvic area, in the groin, around the buttocks, and then in the axilla, so in the armpit, and then on the extremities, on the arms, hands, and sometimes even on the feet. So this will be our flow. We'll go through why we need to do this procedure, when we shouldn't do this procedure, contraindications, how we do the procedure, and then any complications. So sorry for the gross picture. It's early for us, not so early for you guys over in Tanzania. So this is treatment for a skin or soft tissue abscess. Abscess is a clinical diagnosis. So you see red, indurated, tender skin with sometimes fluctuant, usually not present with just simple cellulitis. We tend to use ultrasound to distinguish an abscess from cellulitis if it's unclear or if the area is small. Most abscesses should be drained by incision and drainage as definitive management so that we can penetrate the area for antibiotic treatment. Usually antibiotics alone is insufficient because the area is walled off and it's unable to be penetrated by the antibiotics unless it's opened with some sort of needle or scalpel incision. So important to discuss some contraindications to doing a bedside incision and drainage in the emergency department. This would be a large, deep, complex abscess. So something like somewhere in the abdomen that would be very difficult to access. If you have a pulsatile mass, so if it's something that's protruding off the abdomen or anywhere else in the body with pulsatile, that might indicate to you that this might have a lot of vasculature, a lot of vessels that are in the area. It might have a lot of bleeding if you were to open it in the emergency department, and you might want to consider specialist involvement in the operating room or with people who are equipped to handle a lot of bleeding. Proximity to vital neurovascular structures. So things on the face where you have a lot of nervous innervation, anywhere in the neck where you might be very superficial to the carotid bundle. And then in the groin, if you're very near the femoral bundle, you might consider specialist consults. If anything that has a foreign body inside for safety. And then there are other certain anatomical locations that may warrant specialist intervention. So pilonidal abscess, this is inside the gluteal folds. These can have fistulas to the skin or may track. So have areas where the abscess itself is formed tracking under the skin. These sometimes require surgical intervention for definitive management to remove the entire structure to prevent recurrence. Also very close to the rectum. This also, if female patients come in with a periareolar abscess, you might want to consider a specialist intervention. Some that are very close to the genitals, some that are very complicated in the armpit region. And then, like I mentioned, certain neck abscesses might want the ENT or the ear, nose, and throat doctors to look at. And then consider if there's very cosmetic regions on the palms, the soles of the face. They're also very sensitive. So gathering your equipment, it's pretty straightforward. You want it clean and numb first and foremost before you gather all the equipment to incise with something sharp, and then to clean it all out and get all of the pus that's developed inside the abscess out, and then something to cover it up. So this is generally what I look like when I'm going to do an IND, because you never know the trajectory of when you start to express the pus from your abscess. I've had parents that have gotten in the way of some pus, so I generally like to have them out of the way, even though they're very curious about what's going on. So we'll go through the equipment very briefly. So first, you'll need any kind of cleansing agent to sterilize the area. It's not a sterile procedure, but just something to clean your area. Then you'll use a numbing agent. This is a very painful procedure. So on the next slide, we'll go over more thoroughly analgesia, pain relief, but something to numb the area. So we, in the United States, we use topical LMX, so 4% lidocaine topical, or something called LET, which is lidocaine epinephrine topical. Sometimes even this on the skin is enough to start to express the pus, and it doesn't even require an incision, and then we can do manual expression. So we put that on first. If it's not enough for the child, we can do injectable 1 or 2% lidocaine or lidocaine with epinephrine. Then you'll need a scalpel to create your incision. You'll need a blunt dissecting tool, so a curved hemostat or something similar. You do not want to insert anything sharp once you've made your incision. You put that back. And then to break up loculations or to explore the pocket, you'll use something blunt, so something like a curved hemostat. You'll have normal saline for irrigation. And then some large abscesses will require a packing material. So there's iodoform is one, and plain gauze is another option. It's not always required, but if a wound culture is desired, so for perhaps an immunocompromised child who is developing recurrent wounds or multiple abscesses, if they're not responding to typical antibiotic therapy and there's concern for an atypical age or organism that's causing your wounds, you might want to collect a wound culture. So you'll want to gather some swabs. Some large abscesses might require the placement of a loop vessel, which we'll also discuss. And then, of course, a dressing to put over it when you're finished. So this is what I mentioned prior. So this is a painful procedure. This definitely requires appropriate analgesia, and we often, in certain age groups, will require deep sedation in our emergency department to help with, like Dr. Greenky mentioned at the beginning of the talk, help keeping the child still as well as comfortable. So depending on the age of the child, we always will start with the PO medications and the application of a topical agent to numb the skin. Older patients, it might be appropriate to use some sort of procedural anxiolysis or some sort of procedural medication such as Versed, a benzodiazepine such as midazolam, or a dose of fentanyl. And they might be sort of sleepy, but generally awake. They can do with distraction techniques, talking to their parent, being on their cell phone, reading a book, watching TV. And then generally for like school age or toddler children, deep sedation might be needed, requiring propofol or fentanyl with a sedation procedure. This helps them keep still and comfortable and to endure the pain of the incision and the drainage, as well as the placement of a loop vessel if that's required. It also has been suggested that a regional block could be used. So anesthetizing the area with a regional block, especially something like a hand, a finger, extremity, things like that. Okay, so the actual performance of the procedure is quite straightforward. We've kind of already talked about it in going over the materials themselves, but I'll be a little more specific here. So we talked about cleaning. We've talked about achieving adequate pain control and sedation. The child is now comfortable and still. So you will want to find the center or the most fluctuant part of the abscess. That'll kind of give you the most bang for your buck, or at least that'll be the area where you might express the most pus. Once you've made your stab incision, you'll then put the scalpel off your field, and then you'll use the blunt object to dissect and deloculate or break up the cavity. You can press with your hands around the abscess to get that pus and facilitate the drainage. It's also important not to probe inside with your fingers, just like you shouldn't use the scalpel to injure the patient. In case there was a foreign object that was missed on ultrasound or something, it's important in case there's a foreign object, you don't want to cut your own fingers if you were to stick them inside the cavity. Once you have determined that you've completed the drainage, you irrigate inside with normal saline to clean out any remaining bacteria or pus that's in there. The general rule of thumb or general consensus is for an abscess that's larger than 5 centimeters, you would pack it with the iodoform or the gauze, the packing material, and you leave a tail outside of the incision so it's able to be removed. And so you don't lose it inside. Those patients will require follow-up to have it removed and they'll have the wound examined. And then you'll cover it with a dressing. So these are left open and they're not sutured closed. So these are left to close by secondary intention. So as I mentioned, a loop vessel, this is a rubber string that is placed to help keep the cavity open and allow continuous drainage. It helps the family at home kind of help keep the drainage going. You wiggle it every day, a few times a day, and it helps facilitate healing of this wound for a large wound. So the photos on the right side will show how the object or how the loop vessel is placed. So after you do your first incision and you've broken up your adhesions and you've done your drainage, you will actually create a second incision about an inch, so about a centimeter and a half away from your first incision, and you will connect the two with the hemostat in with the loop vessel pinched in your hemostat and drag it through to create a loop. And that will help keep the wound open so that the cavity can continue to drain any pus or any wound or drainage that continues to develop. Those will be assessed by the doctor or a primary care doctor. And once the drainage stops, it can be removed. Usually that takes about a week to 10 days. Families will find also that it can be I prepare them in the emergency department that it will continue to drain. The gauze, we send them home with gauze because it will continue to be wet. It will continue to be saturated. So to not be worried that this is what's supposed to happen and this is that it's healing. So here's just some aftercare that I always like to prepare families for, because like I mentioned, they get worried that, it's still, the stuff is still coming out. We should have gotten it all out, things like that. So these will resolve. They'll take about a week to 10 days to fully resolve. We recommend that the patient take warm baths in just some clean soapy water to help facilitate the healing of the wound. If we place the packing, we have the patient evaluated sort of every 24 to 48 hours. If it's still draining, it gets repacked and rechecked. Once the draining stops, then the patient follows the normal healing protocol, which is the wet soaks, and then it should heal up in about a week after that. And then kind of like I've already mentioned, if the loop vessel was placed, a week to 10 days of drainage, you wiggle the loop every day, and then once it stops, you can cut it and remove it. So I won't go over every tiny word on this, but this is our management protocol from our emergency department in Atlanta. So this helps us first determine between plain cellulitis without purulence, so without any pus formation, and then management based on the size of the abscess. You will see that generally anything over a centimeter with pus will be drained with incision and drainage. And then we generally send patients home with antibiotics to help facilitate complete healing and treatment of the abscess. There are bacterial infections. And usually the first choice will be Bactrim or clindamycin. Sometimes these patients will also get cephalexin. Usually the cephalexin is for cellulitis on this left side of the screen, and then the abscesses will be Bactrim or clindamycin. And then here's just another kind of version of the same thing that I said. So another hospital, this is CHOP. They say drained abscesses with or without cephalitis, you can choose Keflex, you can choose clindamycin or Bactrim for these. And these have a different, more kind of tailored out by risk factors. Just a quick note on complications. Complications are generally, and luckily they're quite uncommon in these procedures. Usually they're the result of inadequate or overaggressive drainage. So if drainage is inadequate, there would be infection that was inadequately treated. It might extend locally. It might reaccumulate into a larger abscess. The infection may extend into the bone, into the muscle, into the tendon, might develop a septic thrombophlebitis, of course, worst case, necrotizing fasciitis or a fistula. This is sharp dissection, so there might be damage to any adjacent structures. And of course, when we introduce an object into the skin, we don't want to introduce any more infection. So we're always wanting to make sure that we're cleaning our objects and the skin. And then, of course, lastly, like I mentioned, this is very painful and we don't want to cause any further trauma to the child. So we do want to make sure that we're appropriately sedating or providing pain. And sometimes it can be inadequate and can lead to pain, excess pain or trauma. And then the last thing to go over is this is important because we want to always make sure we're talking about when to return to the emergency room. So this is a bacterial infection. So we always tell parents and older adolescents, because they know their bodies as well, to be mindful if in the subsequent days, especially if they're on antibiotics, to look for persistent fever, any signs of systemic illness, so fever, chills, sweating. If the wound is getting worse instead of better, so increased swelling or redness around the area, persistent pain in the area, including the muscles and joints. So that might be what I had just mentioned, that spreading infection, and then any type of foul odor from the wound indicating that there's reaccumulation of the pus. Okay, thank you all for your attention. I'm happy to take any questions at the end of our lecture. This is one of our puppies that can sometimes help provide some comfort for our kids in the hospital.
Thank you very much, Dr. Hannah, for a very nice presentation, and I'm sure the participants have learned a lot. For anybody who has a question, as always, you can just put it on the chat and our presenters will be answering. So now move to the next and the last interesting presentation from Dr. Asha, whereby she's going to be talking about foreign body removal at emergencies on the common foreign body that presents at the emergency. It's another interesting topic that's going to wind up our today's talk. So Dr. Asha, you're welcome to present.
Thank you very much. Good afternoon, my fellow Tanzanians, and good morning there in the US. I am Dr. Asha. I'll be presenting foreign body removal in pediatric patients. I'll be focusing only on the nasal and ear foreign bodies. Okay. All right. This is what we're going to talk about. We're going to go through the introduction, the principles of foreign body removal. Do you hear me? Okay, thank you. Foreign body removal techniques, comforting measures, and also the complications of foreign body removal. Foreign body is anything extraneous that has entered the body, whether it is in insertion, ingestion, or aspiration. It can either be accidentally or intentionally, and this can either be animate, like insects, things like cockroach, and also maggots, and also it can be inanimate, like seeds, rocks, and button batteries, magnets, and others. They're very common in children who are under 5, and also development-delayed people, and also patients with psychiatric illnesses due to the curiosity nature of them. So their inclination to to learn what is happening with this. What if I put it here? What will happen? And things like that. Principally, foreign body removal requires adequate exposure. You need to expose it very well so that you can be able to remove it. If you can't see it very well, if you cannot expose the patient very well, it can lead into complication and even further dislodging of the foreign body that might complicate the removal. Also, the patient must be very well relaxed, whether it is sedation or you can give some sort of distracting measures that will make your patient be relaxed. It's good for the patient. And also you need adequate lighting. You can either be using a headlight or a pen torch or something that will give you adequate lighting so that you can visualize your foreign body. You should be having adequate skills for removing foreign body, and also know your limit. They say there is no absolute contraindication for foreign body removal, but limit you from taking out that foreign body. Might be lacking some instrument that will help you to remove that foreign body. That's a limitation for you to take it out. Please take that patient to the next level where they can move it. Also, you need to explain the procedure to either the patient, parent, or the guardian so that you can be well relaxed and they can be able to cooperate with you while you're removing the foreign body. And also, you have some concept. This is the instrument. For ear, we need an otoscope with have an operating head, that will allow you to put some instrument while you're observing that foreign body in the ear. Also, you need ear or nasal speculum, the headlights, the hooks and curette, the alligator forceps, catheters. Depending on the different types of the foreign bodies, you might even need a magnet. So the foreign body itself will dictate what kind of instrument are you going to use to remove it or to retrieve it from where it is. Okay. Starting from the ear's foreign body, the patient will have different symptoms depending on the time of insertion. Most of the time for pediatric patients, they present late. They might insert it a week later. That's when you realize they might be having a foreign body. So they might come in with signs of infection, or just early signs like pain, fullness, impairing hearing, and they can even present with signs of tympanic membrane rupture, like tinnitus, vertigo, and bleeding from the foreign body itself. What are the distracting measures that can be used? Number one, it can be as simple as showing them a toy, the fun toy, or doing some activity with their mom or dad, or sometimes having the video, maybe a cartoon or something in their phone or the tablet. And also you can give them topical analgesics like lidocaine. You can even go further and give them intravenous and also procedural sedation and even general anesthesia if required. Okay. On the ear foreign body removal, one thing you have to know is to familiarize yourself with different techniques, because the foreign body removal depends on the consistency of the foreign body, the shape, structure itself, size, and also and also the patient himself, so him or herself. Okay. One of the procedure that can be used is irrigation. This is indicated in patients with very small foreign bodies, like sand or dirt or maybe a small rock that can be removed easily. But it is contraindicated in patients with vegetables because they have a tendency of swelling and hence complicating removal. The other thing is if the patient have a tympanic membrane rupture or evidence of tympanic membrane rupture, about perforation, you're not supposed to use irrigation. And also in patients with button battery as a foreign body in the ear, you should not use irrigation because it can enhance current flow and further causing caustic injury. How is it done? It's as easy as taking a 10 or 20 cc syringe or a 50 cc syringe, and you mount a cannula, a gauge 16 cannula without a stylet, or you can use butterfly cannula like this. You just chop a piece and discard the remaining part with which has a needle in it. And this is what we're going to use for irrigation. So we use warm water, like warm to the body temperature water, and you irrigate it upward. You squirt it upward to the external auditory canal. It goes behind the foreign body so that it can be retrieved very easily. It can be pushed out by the pressure of the water from the external auditory canal. Another technique is by using a suction tip. They come in different sizes, and you just connect them to your wall-mounted suction, and they work very well. They're very good in non-graspable foreign body, like the round foreign body like this one. As you can see, this suction tip is grasping it after being connected to the wall suction machine. So you turn on a suction at a very, very low pressure, and you insert it in the ear. It grasps that. It sucks that foreign body, and you remove it out. The other technique, these are the manual extraction techniques. It's a use of instruments like alligator forceps, the curette, the wire loop, and the right angled hook. We're going to see it in the next slide. How do they work? They're commonly associated with abrasions and some bleeding in the external auditory canal, but one of the best, I think we use most of the time we use these ones compared to other techniques. We can use, okay. All right, so I think you have understood there. And for this image is on letter B here. This is how irrigation is done. You aim it up, and then the warm liquid or water will come out and retrieve that foreign body. These are the forceps that I wanted to show you, like the image, the video that you have seen with the indications. The other technique is by the use of catheters. We can use a Fogarty catheter. It's either a biliary or vascular catheter, or we can use a small Foley catheter that we normally have in our setting. Though a small Foley catheter, there is a lot of failures that have been reported, but we can use either of those. What do? You just attach a catheter in a syringe, and then you insert that catheter beyond the foreign body. And then if after passing the foreign body, you have to inflate that catheter, the balloon of the catheter, and then you pull out or retract it slowly so that the foreign body can come out. But be wary of rupture of tympanic membrane. If the patient presents with acute pain, can you please, you have to deflate that catheter immediately, the balloon of the catheter immediately. Okay, another technique is by the use of glue. This was introduced very early times by Indians. Actually, they use super glue, and they put they apply a super glue at the tip of either the swab, a cotton tip swab, or they can put it on any hollow plastic that allows the super glue to be spread evenly. And then you have to you attach it to the foreign body, and then leave it for around 60 seconds for it to dry there. And then you pull that foreign body that is by that time has already stuck to your tip, that was glued tip, and then you'll get out the foreign body. But this works very well if the foreign body is dry and that foreign body is easily visualized because of the risk of trauma. If you cannot visualize, do not blindly use this procedure, please. The other thing is the removal of insects. This is a special part because insects, when they are alive, they cause pressure and pain to the ears, the ears of the kids. So the most important part is to make sure that they either paralyze or they're dead so that they can be immobile in the ear. So you normally use a lidocaine or mineral oil to paralyze the insect. And also you just do manual extractions after that. But make sure that you flush very well or irrigate very well after removing, so that you can remove all the parts of the insect, so that you can avoid risk of infection after removal. This is an image of the baby whose insect was removed from the ear by using an alligator forceps, like we explained earlier. The complications. First of all, it's very important to remember to document all the examination before and after removal of the foreign body, and not all the injuries before. And the good thing is skin injuries in the external auditory canal heals very quickly. So the minor lacerations which are commonly occurring, they should not make you worried, but you should be worried of tympanic membrane perforation. Other complications are like external auditory canal bleeding, infection like acute otitis, external acute otitis media, and even hematoma in the external auditory canal. Other minor complication, I call them minor because the procedure related, like nystagmus, vertigo, nausea, and vomiting. They could be due to irrigating the patient with either too warm or too cold water. So make sure that the water you're using is at the body temperature warmth. Okay, let's now move to the nasal foreign body. Nasal foreign bodies has a potential of dislodging to the airway, so you should be very aware with them. And common objects like the previous ones, they include the peppers, sponge that could absorb the water and become bigger than the initial size, and the living organisms. and also button batteries that are very, very dangerous because they can cause septal disruption and also destruction of the cartilage and cause sudden deformity, which cosmetically is not good. Symptoms, most of the time patients will present with unilateral symptoms. If the foreign body is placed in one nostril, they'll present with unilateral sinusitis, discharge, recurrent unilateral epistaxis. You should be worried with that kind of patient. Those because most of the time the patient will the baby will not tell you that I placed something in my nose until 2, 3, 4 days. That's when you realize they're presenting. I mean, they have some sort of a discharge or they have something I don't understand from their nose. Okay. How do you remove the foreign body in the nose? First of all, let's start with anesthetics. Local anesthesia is not necessary, though we can use a vasoconstrictor if you need for making the examination easier, but you don't necessarily need to give local anesthetic. Though some literature says you can use local anesthetics mixed with lidocaine mixed with epinephrine as the local anesthetic and the vasoconstrictor together. Also, if the child is uncooperative or if the foreign body is very much posterior, you need to use procedural sedation or general anesthesia. Now let's go to the technique. Technique number 1 is the positive air pressure. These are very simple procedures, but in a way they're complex. Now, number 1 is asking the child to blow their nose while they're cleaning the unaffected nostril. This can be done very well by the baby who is cooperative, who is older, who can understand the instructions. But for younger kids, this is not possible. The other positive air pressure technique is by a parent kiss. Parent kiss and BVM both, they have a similar technique. For a parent kiss, you just ask the parent or a guardian or a trusted relative to blow to a child's mouth while occluding the unaffected nostril. So they use their mouth to cover the baby's mouth very well, and then they blow some air into the mouth, but occluding the unaffected nostril. This will push the foreign body forward. Whether it can remove it, retrieve it using other procedures. Also, BVM works similar to parent kiss technique. So you use your mask and occlude the mouth only, leaving the nostril. You occlude the unaffected nostril using one finger, like it's seen in the image here. And then you use your bag and give a little bit of air. So this will create a pressure that will push the foreign body from wherever it is to come outside. If it doesn't come out, then it's going to be closer to, in the anterior, so that you can be able to remove it. Okay. After that technique, the other technique is manual instrumentation. This is similar to what we did in the ears. So by using forceps, the wire loops, also by using the suction tip catheter, it's the same thing like what is done in the ears foreign body, and the indications are the same. So here, the other thing is by the use of balloon catheter, similar technique like in the removal of ear foreign body, but there's a special catheter which is called CATS extractor. We don't have it in our setting, but we normally use the Foley catheter. The technique is the same. Inflate air like for Fogarty catheter and Foley catheter, you inflate around 3 to 4 mils of air or water. After insertion of your catheter past the foreign body, and then you retract it back so that you can remove the foreign body. For this CATS extractor, you just insert, you inflate it with just 1 cc of air. That will help you to retrieve the foreign body after it. These are the complications. They can be as simple also injury to the nose, like nosebleed can occur. After removal of the foreign body, make sure that all parts of the foreign body have been removed, okay? And also check and recheck both orifices that the child would possibly put a foreign body, because they have a tendency of putting in one or more orifice. So if there's ears, check another ear, check another, check the noses too before you discharge that patient, to be sure that all the foreign bodies have been removed. And when do you consult ENT? First, when you are unable to remove after multiple attempts, and when the foreign body is tightly wedged, and when the foreign body is resting against the tympanic membrane for the ear foreign body, the sharp object, and the button batteries. This button batteries requires early ENT consultation. As early as you realize they have a button battery, it should be removed within in less than 4 hours of insertion, because of the complication that could occur after button battery insertion. And that marks the end of my presentation. Thank you very much.
Okay, thank you very much, all the presenters. It has been a very lovely presentation, and I'm sure all our participants have enjoyed the presentation.
Well done.
So as I initially said, we have had a very good year since the beginning of January, where we began our PEM lecture series. Today marks the end of this year's PEM lecture series, and then we'll now prepare for the next PEM lecture series beginning in January. As of today, we will really like to say thank you to all the participants that have joined in. And just again, to repeat what I said at the beginning, we're very happy this year to begin a new super specialization course, that is Masters of Science in Pediatric Emergency Medicine. And we're glad to have 3 PEM fellows who are gladly presented today, Dr. Asha, Dr. Biita, and Dr. Mbugi, who are our newly enrolled Pediatric Emergency Medicine fellows, super specializing. And this course has begun this year and it's going to be enrolling next year as well. For all that have completed their MMed Pediatrics or MMed Emergency, you're warmly welcome for the next year enrollment to keep on learning with us. Having said so, I would like to say in advance a Merry Christmas and a Happy New Year 2026, and wishing you all happy holidays, and we'll meet again in January, and we're gonna update you on when it's gonna be our next presentation. Thank you all, and have a lovely evening for us in Tanzania, and a good morning to our colleagues in the US.
Thank you, Chair, for